It's my honor to present our research from the iSCAD Registry on pregnancy-associated SCAD with all these wonderful authors listed. Really no introduction, I think, needed for this session to really underlie that pregnancy-associated SCAD is a major cause of myocardial infarction or heart attack associated with pregnancy. But really, as my colleagues had highlighted, there's really a paucity of reproductive and obstetric data sort of surrounding the pregnancy period that we understand of women that are affected by pregnancy-associated SCAD. And so really that was our primary goal, was to look at reproductive variables in women, Paris women, or women who've had any pregnancy prior to or after presenting with SCAD. From the iSCAD Registry, we had a total of 907 women, and of those, 98 had SCAD that was associated with pregnancy, as Dr. Grzinski highlighted, could be postpartum, as compared to 809 patients who had SCAD that was not associated with pregnancy but had a pregnancy prior. We looked at many reproductive variables, of which we compared between groups if we had them, and also to the general US population. We were also really interested in details about the SCAD itself, as well as some psychosocial variables, and we used statistical methods to really compare these two groups and to compare our p-SCAD group to the general population. And these are the results. Looking at the table over here on the right is our baseline demographics. One thing to highlight is the median age among the women with p-SCAD, those 98 women who had SCAD around pregnancy, was the median age at time of their p-SCAD presentation was notably older, around an average of 37 years of age, as compared to, say, the US population of women during pregnancy, which is closer to 29. We did have a really beautifully diverse cohort of women in this iSCAD registry who were kind enough to fill in their details. We 1 in every 4 patients self-identified as not white, so we had a number of different races and ethnicities within this cohort. When we looked at the two groups of patients with pregnancy-associated SCAD and women who had been pregnant in the past but SCAD not associated with pregnancy, what we saw is women with p-SCAD had less cardiovascular risk factors and less fibromuscular dysplasia than their non-pregnancy associated SCAD counterparts in the registry, but similar extracoronary vasculopathy, including aneurysm and dissection, which was present in both categories or subgroups of patients, somewhere around 14 to 17%. And we were proud to see that over 85% of patients in the iSCAD registry really had to pelvis screening for extracoronary vasculopathy. When we focused in on the reproductive features, what we saw is patients with pregnancy-associated SCAD had greater multigravida, meaning they had greater chance of having multiple children prior to their p-SCAD event. They had greater use of reproductive assisted technologies, including greater use of IVF than their non-pregnancy-associated SCAD counterparts. Women with pregnancy-associated SCAD had greater incidence or history of preeclampsia associated with pregnancy, and we did see about 66% reported breastfeeding on or around the time of their SCAD event. When we focused in on the SCAD event itself, what we noted was indeed what prior literature that Dr. Grzinski and Dr. Scott had highlighted, is that the subgroup of women with pregnancy-associated SCAD had greater rates of ST elevation or MI or EKG, more severe findings on presentation. When they were taken to the cath lab, they were noted to have SCAD that was impacting more vessels on diagnosis and more segments within the vessels themselves on diagnosis. And then when we looked at, particularly during that hospitalization, their major adverse cardiac events, we noted that women with p-SCAD had more in-hospital major adverse cardiac events, which was really driven by recurrent MI or myocardial infarction during that hospitalization. To note, most patients, about 75% in both groups, were conservatively treated, meaning they didn't go on to have stenting or coronary artery bypass associated with this event. And notably, there were no deaths in both subgroups. And so just to summarize what we found in this paper were that in comparing women with pregnancy-associated SCAD to women with non-pregnancy associated SCAD in the iSCAD registry, both had similar rates, again, that 14 to 17% of aneurysm and dissection, so very important to screen all patients or to look for extracoronary vasculopathy in all patients, pregnancy-associated or not SCAD. Those with p-SCAD had greater maternal age than the US population and reported greater use of assisted reproductive technology, as well as greater incidence of preeclampsia associated with pregnancy. Regarding the SCAD event itself, women with p-SCAD had greater STEMI presentations, greater in-hospital major adverse cardiac events, and also less cardiac or left ventricular recovery likely subsequent to these things. Despite that, both groups were mostly conservatively treated without stents or artery bypass, and there were no in-hospital deaths in either group. All right, thank you so much for having me share.